Okay. Hey, everybody. Sorry for the delay. A little bit of a technical difficulty there, but we've got it all sorted out, and we're ready to go. So welcome to the live hangout here, the webinar. I'm Antonio Chirumblo, Head of Content at newgradoptometry.com. And I'm here tonight with Dr. Eric Botts, practicing optometrist, who also happens to be the president of the Energize Association and the founder and doctor of Innovative Eyes Clinic, and the founder and CEO of Optometric Billing Consultants, insurance billing and credentialing specialists. Needless to say, Dr. Botts has a lot of experience when it comes to credentialing along with billing and coding. So he's going to be sharing a ton of great expertise with us tonight. So we won't keep you guys waiting. We'll just kind of get right into it. And Dr. Botts, I'll just hand it over to you.
Very good. Well, thank you, Antonio. I'm excited to do this presentation, especially to share my experience and everything I've learned over the last 26 years with a whole lot of students who, or first year practitioners who really, the way I understand, you don't get a lot of experience with coding and billing in school. I know I didn't. So you've got to learn it as you go, and I think this is a great opportunity for you to pick up on some information on things that you probably haven't seen before. So we're going to talk here for maybe an hour and a half or so. Questions you're more than welcome to ask. And I'm going to share as much information with you as I can. Now you'll see here on this first slide, there is my email address. Anybody is welcome to send me questions when they've participated in a presentation. So when we get done with this presentation, you will have questions, and feel free to fire away, and I'll try to respond usually within 24 hours.
And Dr. Botts, just so you know, we've got a live chat going as well. So feel free to submit any questions during the talk here, and we'll answer them as we go as well, in case anything pops up. So okay. Sorry for the interruption. All yours.
And Antonio, you're going to see those.
I will.
And okay, all right. Just cue me up whenever you see a question. So a little bit about OBC Billing Specialist. This company actually came about from me sharing some information with a group of doctors in my area, and them wanting to do the medical billing model of optometry, but really not knowing how. And it started about 12 years ago with a couple doctors who wanted me to do their claim submission, which I did. I hired a person to do all of our billing for us, and it's grown from there to hundreds of clients at this point in time, and I currently have about 40 billing specialists, and we can submit claims and we can credential doctors in all 50 states. So there's no insurance panel or no state that we cannot be successfully submitting your claims in. So we offer a lot of education, much like we're going to do tonight. This presentation that I'm doing tonight is actually a portion of a presentation that I've done over 200, probably 275 times nationwide. Tonight you're getting a little briefer version. Typically this presentation is going to go for about 6 hours, but quite honestly, I don't think I can go 6 hours tonight. So we're going to cut it down to about an hour and a half. So first of all, you got to understand what is medical coding to an optometric practice, and it is truly an opportunity to grow your patient volume and grow your fee-generated income. There's no better way to take care of your patients than to provide them the medical care they need and help them submit their claims to insurance so that they get reimbursed for the insurance that they're paying premiums for. And the biggest reason to do this is because it's a huge opportunity in that so many patients today have some kind of insurance. Almost 9 out of 10 patients have some kind of medical coverage, and that makes for a huge number of patients that you can see and help help them utilize their health insurance. Medicare alone today probably has in the 50 to 60 million recipient numbers, and that's only going to grow in the next 10 to 12 years. That's probably going to grow to over 80 million, and that equals almost 1,000 patients per doctor. So there's just lots of Medicare patients out there that need ocular care, and you can help them, but you really need to be a Medicare provider if you're going to be able to take care of all their ocular needs. So there are some initial steps for building a medical optometric practice. The first thing I would suggest, as far as establishing your fee schedule, is look at Medicare's allowables. I think that's a good starting point because it's kind of a middle of the road fee schedule. There's other insurances that are going to pay better, and there's some insurances going to pay worse. So I think that's a good starting point. I think you need to treat everything your license allows, and charge for every procedure you perform. You're not doing anything necessarily for free. Really, there's no doctors, dentists, any healthcare providers out there that provide a lot of care for free, optometry included. You need to charge for what you do, and you got to be prepared to invest in technology. The way we practice today has evolved significantly since when I started 26 years ago. And the technology is probably the biggest improvement. So investing in a retinal camera, OCT, EHR, keratograph, tear lab, all of those instruments that are going to help you be a better clinician, provide better care, are things you're going to have to invest in. If you do all three of these things, the potential to grow your practice is huge. When I first did this over 10 years ago, my initial increase in gross income was over $71,000, and that was a long time ago. But that was a huge increase in income for me, and that's how you pay for the new technology. That's how you pay for the camera and the OCT scan and all the new technology that's available to you. You need to understand that patient communication is really where it starts. And the education starts with you. And it starts with you and the patient that's sitting in your chair. Because currently there's really nothing out there today that is promoting what optometrists can do to the general public in any significant way. So the best way to communicate to patients today is to communicate to the patient sitting in your chair. Explain to them that you can help them with their ocular care. You got to explain to them what are the different procedures you can do, that you can monitor their diabetes, you can treat their glaucoma, you can monitor their cataracts, you can treat their red eyes. Whatever it is that you can do, you need to let the patients know. You need to also help them understand how to use their insurance. And some patients won't have any insurance, but most will. Most will have health and vision insurance, and some may just have health insurance only. You need to be able to talk intelligently to your patients about what the potential is for them to utilize either their health insurance or their vision insurance. Now, how do you explain a medical exam versus a routine exam to your patient? And I think there's some simple steps you can follow here. And then I'm going to give you some tools that'll make it easier yet. But first of all, I think the first thing to think about is what is your primary diagnosis for the exam? If it's a routine refractive diagnosis, and that's the primary diagnosis, then typically you're doing a routine exam. But if the diagnosis that is primary for the exam is a medical diagnosis, then I think you have to look at this as a medical ocular eye examination. And when it comes to explaining to the patient, because many patients are going to come in and they're going to want to utilize whichever insurance is going to cost them the least amount out of pocket. The reality is it doesn't work that way. The reality is the type of exam you're performing is going to dictate the insurance that you are going to submit the exam to. And this is basically using the rules and guidelines of the insurance companies themselves. And that's why I every day when patients ask me about insurance and I explain to them the policy that I utilize, which is if it's a routine exam with a routine diagnosis, we'll submit to routine insurance. And if it's a medical exam with a medical diagnosis, we'll submit it to the medical insurance that's following the insurance panel's rules. And basically, if a patient objects to it, I just explained to them that following the rules is the only correct way to do it. And so basically, I do throw the insurance company under the bus occasionally and blame it on them as to why we are going to utilize whichever insurance panel we're going to do today. So this is a form that I utilize quite often for explaining, first of all, starting with your staff to make sure you, the doctor, and your staff are on the same road here as far as what's medical and what's routine. And this is a form, if you are interested, you can send me a quick email and I'll be happy to send this form to you so that you can have a PDF copy of it to utilize. And that way you can customize it and make any changes you want. But this form will explain the difference between a medical exam and a routine exam in layman's terms so that your patient can understand why you're utilizing medical insurance when you do. And also explains that basically you're just following the insurance guidelines. And you know, that is the correct ethical way to do it. Now, before you start a medical optometric practice, there's some things that you have to do. And this is important for those of you who are just coming out of school, just getting started. You need to select your insurance panels and you have to get credentialed for them. And folks, that's a time-consuming event that can take several months. And some of the insurance panels can take up to 6 months to actually get credentialed and be able to see those patients. So you got to be prepared for the fact that this is going to take some time. Then you have to decide, how are you going to submit your claims? Electronic submission by far is the best way to go. Sending paper claims is probably the most inefficient way to go and is going to lead to the most denials of your claims. So I'll explain to you in a moment different ways that you can submit your claims electronically, and I'll go through that in just a little bit of detail here shortly. But you also have to understand how to properly code and document your exam. And we're going to touch on that a little bit tonight. And honestly, folks, there's a lot more that you'll need to know, but we'll touch on enough tonight to get you started. So as far as the insurance panels that you should join, it's really going to be dependent on where you practice, what are the major employers in your area, and which routine vision plans do they have, and which medical plans do they have. So that's one way to decide, is look at your employers. Also, I would encourage you to become a Medicare provider, because Medicare, as I showed you earlier, has millions of recipients nationwide. There's really no community today that doesn't have Medicare patients in it, and quite honestly, that is one of the fastest growing populations in our country today. So Medicare, I think, is one that I think everybody should apply and credential for. As far as routine insurance goes, I think there's maybe a little bit of a separation here, as if you're in a corporate location like myself, you know, Spectera, Davis, Avisis are probably some of the insurance panels that you are going to immediately apply to get on. If you're in a non-corporate location, then VSP and IMED may be the insurance panels that you decide to apply for. They do tend to discriminate a little bit against corporate doctors, especially VSP. For many, many years, including currently this year, I can only be an affiliate provider for VSP. I cannot be a participating provider. IMED is a little different in that they're owned by Luxottica. So any corporate doctor working under a Luxottica brand is obviously going to be an iMed provider. So lots of options there as far as the routine vision plans go. Some pay better than others, so you just have to look at what your options are and make decisions based on where you practice. As far as medical, oh, go ahead.
Question, Dr. Botts. So when you're looking at the list of panels there, the routine and the medical, when you're going through the credentialing process, is there an ideal panel you should join first? Should you focus on getting credentialed with Medicare first? Is that the kind of the first nut to crack?
I would suggest Medicare first, as far as medical insurance goes. And then after that, I would look at CAQH application, which you can start by initiating an application to one of the other medical insurance panels. And Blue Cross Blue Shield is probably the most popular commercial plan or carrier in the country today. So I think Blue Cross Blue Shield is definitely one that you should look at. Unfortunately, there are certain areas in the country where Blue Cross Blue Shield is very difficult to get on. Florida being one of them, especially Southern Florida. So unfortunately, there is some difficulty in some parts of the country on getting on some of these panels. Medicare, however, is open to everybody. So anybody can get on Medicare, and that's where I would start.
Great, thank you.
And then you can see, I have Medicaid on both lists because Medicaid is both a routine and a medical insurance carrier in most states. I would say there's a lot of variation between how well Medicaid pays depending on which state you're in. So that's one that you're going to have to research a little bit depending on where you're going to set up your practice as to whether or not you'd want to be a Medicaid provider. As far as joining medical plans, the reimbursement is the biggest reason. Here is a good example of what I'm talking about. A 92004 with Medicare allowable in where I practice is $144.18. And a 92004 for routine vision plans that I typically submit to in my practice will reimburse anywhere from $40 to $60. And so there's no question but that medical plans pay better than routine plans almost always. So to begin the credentialing process, which you want to do is as soon as you graduate, as soon as you apply and receive your state license, that's the first step. Then you need to apply for an individual NPI number. And there's the website there that you can go to apply for that. You want to get a tax ID number for your practice. And once again, there's the website that you can apply for the tax ID number. And those are fairly short process to do either one of those. And then if you're going to incorporate, or if you're going to have a group practice, then you need to get a group NPI number after you get your tax ID number. So those are the first 4 steps that you need to follow when you are starting the credentialing process.
Quick question for you, Dr. Botts.
Sure.
When applying for the NPI number, a lot of times we get the question, if I don't know where I'm going to practice yet, or if I don't have a work location, what address should I use in the application process? Do you have any recommendations on that?
Well, I think you're probably going to have to use a residential or your home address, but that would be my best advice, because if you don't have a practice set up, that's about the only thing that you can do. Gotcha.
Okay.
So the next decision you have to make is how are you going to set up your business? You need to be very consistent from the beginning. So you need to make a decision whether or not you're going to be a sole proprietor or you're going to be a corporation. before you initiate any of the credentialing process. One of the biggest mistakes that doctors make is to start the credentialing process initially maybe as a sole proprietor and then decide later on to become a corporation. It really, really complicates the whole situation. So you may want to consult with a lawyer or an accountant to make that decision, because some of it will depend on what state you're practicing in. All the states can be a little bit different. So I don't want to make a recommendation here for everybody. I think it's best that you look at your situation and make a decision with the proper help, which, right out of school, 26 years ago when I started practicing, the first thing I did was get a lawyer and an accountant to get my practice going. So let's talk a little bit about credentialing for Medicare. Medicare is if you're going to participate as an individual sole proprietor, you're looking at a 30 to 35 page application. If you're going to do a group practice or corporation, you're looking at about 60 pages, which you can do online by going to the PCOS website, or if you're having any issues with it or you're just afraid to tackle it on your own, that's something that we do at OBC for doctors every day. And you're welcome to reach out to Kenny Meyer. He's the one that can get the ball rolling for you and help you with the application process. Information that you're going to have, whether you do it on your own or you reach out to Kenny, you're going to need to have your NPI number, both individual and group, if you're going to decide to get a group NPI number, your social security number. You need to have the name of the optometry school and the year you graduated, which obviously you'll know. You're going to need your optometric license number. You're going to need your legal business name. You're going to need a tax ID number. And it's really important when you get that tax ID number and when you incorporate that, you're going to get forms that tell you that you have a tax ID number or that you are incorporated. You need to keep those forms. You're going to need those forms to process a Medicare application going forward from there. So put those in a safe place and hang on to them. Other things that are optional, but I would recommend, in fact, some insurance carriers are going to require you to have these to be on their medical panels. That's a state-controlled substance license and a DEA certificate. And those are things that you can apply through your individual states. So as far as a Medicare application goes, you're going to have to decide if you're going to be an individual single owner or you're going to have multiple owners of a group practice. If you're going to have a one owner practice and you're it, then the 855I is all you're going to have to fill out. If you're going to have multiple owners, then each doctor is going to have to fill out that 855I, and then the corporation will require a 855B application. And then if you're going to reassign benefits from one doctor to another, then you'll have to fill out the 855R. So there's a lot to it, and you have to understand what you're doing when you're filling out the credentialing applications. You're going to have to make a decision as a Medicare provider whether you're going to be a participating provider or a non-participating provider. And I'm going to highly recommend that you become a participating provider that accepts assignment. That's the best way to encourage Medicare patients to come to your practice. Because as a non-participating provider, the patient is going to be required to pay you up front and then wait for you to submit a claim for them to get reimbursed by the insurance. And most patients on Medicare are savvy enough to know that there's lots of doctors out there that are participating providers. And if they go to a participating provider, then all they have to do is pay for the non-covered procedures like refraction, and the exam and any supplementary tests that are performed will be submitted to insurance, to Medicare by the doctor, and the doctor will wait for reimbursement. And most patients that are of Medicare age are on a fixed income, and they're going to pay attention to those details. So highly recommend that you become a participating provider accepting assignment from day one when you apply to Medicare. Now, the EFT agreement, the 588, this is something that you definitely want to participate with, because it means that all payments for Medicare will automatically deposit into a checking account of your choosing. And there's no quicker or better way to get reimbursed than to have the money automatically deposited instead of waiting for checks to come and then having to transport a check to the bank to deposit into your account. The EFT agreement is absolutely a necessity. So a few questions here that usually come up. For example, when should I apply for Medicare? First of all, you need to apply when you have a practice. You have to have a location established, or you have a job secured with a practice that's beyond your internship. Okay, so there's no reason to apply if you don't have a physical location for your office that is up and running. So if you are planning on starting cold and building a practice, you really need to wait until the building is established to start the process for your Medicare application. You need to have an existing building to get the process, to get the application started. Now, this is a good question. When can I start seeing Medicare patients? Unlike many other insurance panels, Medicare will backdate claims, which means once you submit your application and you have an established start date, you can start seeing the patients on that date. However, you're not going to get paid for any claims until your application is processed. Therefore, you can't bill any of those claims until the application is completely processed and approved. But once your application is approved, any patients that you've seen since your established start date can now be submitted to Medicare, and you will get reimbursed for all of those examinations. Now, be very, very cautious about any other insurance panels. You need to make sure that they will allow you to backdate claims, because many will not. There's many doctors that get caught by seeing patients on panels that don't allow you to backdate. And the routine vision plans are notorious for not allowing any backdated claims, meaning that if you're not an approved provider for IMED or Davis or Spectera, and you see patients before you are an approved provider, you're not going to get reimbursed for those claims. So are there any other insurance companies besides Medicare that will allow you to see patients while the application is processing? And Medicaid is one that will also typically backdate claims. And as I said before, most of the vision plans will not. And many of the commercial medical plans like Blue Cross Blue Shield and Cigna and Aetna, they also many times will not allow you to backdate a claim. So how do you get on the other panels like Blue Cross Blue Shield and Aetna and Cigna? And the first thing you want to do is you want to apply to one of those panels, and then you want to start the CAQH universal credentialing process. And the reason you want to do that is because most of the commercial plans will use CAQH as part of the credentialing process. Now, what that means is Medicare, which has that long 30 to 60 page application, does not use CAQH. That's why their application process is so long. You have to fill out everything, answer every question for Medicare. But Blue Cross Blue Shield, Aetna, Cigna, a lot of the other commercial plans, once you've done a CAQH universal credentialing application, then they will utilize the CAQH information to process their application much more quickly than if you had to fill out all the information for each of those applications separately. So the CAQH application is extremely important to get going as soon as you are ready to apply for commercial panels. Now, how do you submit your claims? Now, I said earlier, the best way to do it is electronically. And so you've got different options on how to do that. The most efficient way to go is to have an EHR, electronic health records, that is attached to a clearinghouse, so they're integrated with a clearinghouse. There's no easier way to submit claims than if you have those two in play. Then it's just a question of whether you're going to hire somebody to do it for you, whether you outsource it to a billing service or you hire somebody in your office to submit those claims. Either way, this person needs to be well educated on how to submit the claims. So you're going to have to hire and train and maintain a billing person if you're going to keep them in your practice to do the submission of claims for you, or you can outsource to a billing service. And either way, the person who's doing your claims needs to be able to submit the claims, submit secondary claims, be able to research and resubmit denied claims, and then bill patient for any balance that's due. So oftentimes I get questions on when do I use 99 codes or 92 codes or S codes? And this is a sometimes very complicated question for a lot of doctors. And there's lots of different strategies on how to use these codes. But there's some things that you can see it that are hard and fast rules. Number one being that 99 codes are always medical. So if you submit a 99 code with a refractive diagnosis, it will always get denied. 99 codes always are submitted with medical diagnosis codes. The 92 codes can go either way. Many of the routine vision plans are going to ask you to submit a 92 code, and many of the medical plans will also accept a 92 code. So the 92 codes can go either way. The S codes, which are less frequently used, are strictly for routine exams, and you need to make sure that the routine vision plan that you're submitting to will accept an S code before you submit it, because many of the routine vision plans will deny the S codes, and then a number of them will accept it. And unfortunately, folks, there's no hard and fast rules on what an insurance panel has to accept. They make their own rules, unfortunately, and you have to learn what they are, and then you have to follow them to get reimbursed. So let's talk a little bit about what's the difference between a medical and routine exam. And more importantly, what's the similarities? Because the reality of it is there's a lot of similarities between a medical exam and a routine exam. So let's break it down here into the elements of an exam, and I'm going to explain to you which are similar, which are different, and how do you know. So let's start with a chief complaint. For a medical eye examination, the chief complaint needs to have some kind of medical necessity. You know, either blurry vision, or I have a cataract, or I'm a diabetic and my medical doctor told me that I needed to get an eye exam, or my eye is red. Something along those lines is a medically necessary chief complaint. A routine chief complaint is typically going to be something like blurry vision, or I can't see out of my glasses, or I need new contact lenses, or I'm here because my glasses broke. Those are going to be more refractive in nature. Now, if a patient comes in complaining of blurry vision, quite honestly, you can't tell by that chief complaint whether it is going to be a medical exam or a routine exam, because they could have blurry vision because they need a half a diopter stronger prescription, or they could have blurry vision because they need a half a diopter stronger prescription because they developed a cataract. And until you establish what the cause is for their chief complaint, you won't know whether it's a medical or a routine examination. Now, one of the elements here that is very, very similar between the two, in fact, is exactly the same, is the history. When you're seeing a patient for the first time, there's really no difference between the medical history that you're performing on a medical exam and the history that you're performing on a routine exam. I'm going to do a comprehensive history on every new patient that is sitting in my chair. So the history really doesn't vary between medical and routine patients, mainly because when you're doing the history at the beginning of the exam, a lot of times you don't know if it's going to be a medical exam or a routine exam until you actually establish what the problem is. The elements of the exam are also very, very similar. However, your strategy for performing the elements of the exam can be very different. For a medical eye examination, you choose the elements of the exam that you want to perform in order to diagnose and treat the patients and nothing more. Whereas for your routine examination, you may do the same elements of the exam on every patient in the same order every time. And there's nothing wrong with that. That's perfectly fine. But realize you cannot do every test on every medical patient that walks in the door. You have to pick and choose just those tests that are necessary. Then the next part of the exam is the medical decision making. Now, for a medical exam, you're going to have either a low through high level of medical decision making. And for a routine exam, you may have a low or you may have no medical decision making at all. So this is where you really do differentiate a medical exam from a routine exam, is with the medical decision making. And then, of course, the medical diagnosis. If you have a medical diagnosis that correlates with the chief complaint, and that's very important, that when you have a medical exam, whatever the chief complaint is, it has to be addressed and answered by the medical diagnosis. And with a routine exam, typically the diagnosis is going to be refractive in nature, either myopia, hyperopia, or presbyopia. Now, what if you find a medical problem during what you thought was going to be a routine exam? And you have three choices here. Number one, you can finish your routine exam, suggest the patient come back for a follow-up on whatever medical condition you found. So in that case, you would submit the exam to their routine insurance and set them up to come back either tomorrow or next week, and you'll do a follow-up medical examination that you'll have a medical diagnosis for. Option number two is you can switch gears. You can perform a medical exam today and have the patient return another day to do the routine exam. And I would typically do this most often, especially if the medical condition is going to interfere with obtaining a good refraction. Because essential for a routine exam in my mind is that you have to be able to perform that refraction. And if I can't get a good refraction because, for example, they have a corneal ulcer or some other issue going on that's going to affect the refraction, then I would switch gears, do the medical exam, have them come back for a routine exam. And then the third option is a combination of both, where you can perform the routine exam, submit it to the routine insurance, but let's say the patient, you suspect they have glaucoma. And so in addition to doing that routine exam, you want to go ahead and start the glaucoma workup, and you want to dilate and do photos, or you want to do a visual field test or gonioscopy or any other test that you want to perform as part of that glaucoma workup. You can go right ahead and do that. You can submit the office visit to the routine insurance. You can submit the supplementary test to the medical insurance on the same day. What you can't do is you cannot submit 2 office visits on the same day. You cannot submit an office visit to the routine insurance and an office visit to the medical insurance at the same time, on the same day. That you can't do. Now let's talk a little bit about the 92 codes, starting with refraction. If you're performing a medical examination, and as part of that examination, you're also going to do a refraction, 92015 is the code, and you have to unbundle that from your medical visit. So anytime you're doing a medical exam with refraction, you have to have a office visit code, and then you have to have a separate code for the refraction. And this is important because if you're ever audited and the insurance auditor looks through your records and sees that you did refraction and you performed a medical examination and you didn't separate out the refraction, they're going to require you to pay back a percentage of every exam with a penalty. And so refraction has to be unbundled and billed separately from the office visit. Now you can do a 92002 or a 92012. Those are intermediate or lower level office visits, typically requiring a medical examination and evaluation with either the initiation or continuation of a diagnostic and treatment plan. That is a requirement for the 92 codes. Typically, as part of an intermediate exam, you're going to do a medical history. You're going to do an external exam, possibly tonometry, maybe a limited internal ocular exam. You can have a minimal decision making as part of that exam. Typically, 92002 and 92012 are typically red eye, non-dilated examinations or follow-up visits or for red eyes or other cataracts, things like that, where you're performing a follow-up visit on a previously previous diagnosis. 92 codes can also be utilized for routine vision plans. The 92004 and 92014, these are much more comprehensive examinations requiring the initiation and continuation of either of a diagnostic and treatment plan. Typically has a minimum of 8 exam elements, including the medical history, external and internal ocular exam, some kind of screening visual field, tonometry, and potentially, I would say, a dilated fundus exam is pretty typical with the 92004 and 92014. Also can be used for routine vision plans. And one caveat with the 92004 and 92014 is that it can involve multiple visits for one claim. This is a situation where you may see the patient today and do everything except for maybe the dilation. Maybe the patient says, you know, I can't be dilated today. I need to come back for that. So you have them come back another day. You can bill one code for both visits with the 92 codes. You cannot do that with 99 codes, which we'll talk about here in a moment. The 99 codes, you would have to bill 2 separate codes for 2 separate visits. With the 92 codes, you can actually combine over multiple days. So as far as the 99 codes go, here are the different options you have. It's 99201 all the way through 205. Those are new patients. Requires a medical diagnosis code. And then you have your established patients. Once again, 99212 through 99215 also require a medical diagnosis code. So how do you know which 99 code to submit? Well, here's what I can tell you about that is most medical insurance plans only care about 3 elements of that exam. That's the history, the physical examination, and the medical decision making. Those are really the only 3 things that most medical plans care about. So let's talk about those in detail here. So let's start with the history. As part of a history, you need to have a chief complaint or reason for visit. You can have a history of the present illness or HPI. You can have a review of systems and then a past family and or social history. So let's break that down a little bit. So as far as the chief complaint goes or reason for visit, typically the chief complaint is a brief 2 to 3 word summary of the problem. A lot of times you use your patient's own words. If it's going to be a medical exam, I would never write down, I'm here for a pair of glasses or I'm here for contact lenses. That is probably never going to fly for a medical examination. I have a red eye or I have blurry vision or they're being monitored for cataracts. Those are acceptable chief complaints for a medical examination. And remember, as I said earlier, it has to correlate, chief complaint has to correlate with the diagnosis. Now, reason for visit can be substituted for a chief complaint. And a reason for visit is typically ordered by the doctor and typically can be established by looking at the previous exam that you performed, looking at your plan, and looking at what did you recommend for the patient as far as follow-up goes, as far as when did you want to see them again and why. So if you have a glaucoma patient and you establish that their pressure is well controlled, the drops, but you want to monitor them in 3 months, then you might, as part of your plan, write down monitor for glaucoma changes in 3 months. Then when they come back in 3 months, the reason for the visit is monitor for glaucoma changes. The HPI, or history of present illness, is always performed by the doctor. Now, this is important that you understand that the doctor has to document the HPI. This is Medicare's rule, and therefore you must follow it, which means that you can't have a tech document the HPI. You, the doctor, need to ask the questions and document location. Is it the right eye, left eye, both eyes? Or quality, is it painful, or are you just aware of the problem? What's the severity? Is it just a mild pain? Is it a moderate pain? How long has it been going on for? What's the duration? Has it been going on for days, hours, months? What's the timing? Is this a new problem? Is it an ongoing problem? Or is it the return of a previous problem? What's the context? Is this associated with an injury or associated with a systemic disease like diabetes? And what is the patient doing to make it better? What kind of modifiers are they using? Are they taking medication? Are they using drops? And then what are the symptoms? Do they have red eyes, itchy eyes, tearing, floaters, any of those symptoms? Then you need to do a review of systems. And you might ask yourself, why is an optometrist doing an eye examination? Do I even care about the integumentary system? And the reason is because these are the guidelines set forth by all healthcare professionals. So any healthcare professional that's going to perform a medical eye examination has to follow the same guidelines. So for the same reason you might ask, why do I care about any skin disease or integumentary issues the patient might have? The dermatologist might ask, why do I care about the eyes? And what I'll tell you is this, is when it comes to medical insurance panels, especially Medicare, when it comes to issues like this where they put a hoop in front of you to jump through, instead of banging your head against the wall asking why do I have to do this? I'll just tell you, just do it. Because these are the guidelines that you have to follow. Because these are the guidelines that all healthcare professionals have to follow. And that's not a bad place for us to be as optometrists. When we have to do the same things as a cardiologist as the oncologist, then we're in pretty good company. So this is just one of those things that you're going to have to do as part of a medical eye examination. As far as the past family and social history goes, you want to look at both patient past history and family health history, lifestyle questions, and tobacco products. Tobacco products has become a big issue with meaningful use over the last 4 or 5 years. And it used to be that you just asked the patient if they smoked, yes or no. Now it's if you smoke, yes or no. Have you ever smoked? How much do you smoke? And what tobacco products do you use? There's a lot more involved in what you have to determine from the patient now. Now, as far as the medical history goes, there's basically 4 levels. Problem-focused, expanded, problem-focused, detailed, and comprehensive. As you go down this list, they become much more detailed. I would encourage you to always do a comprehensive history the first time you see a patient. Too much history is never going to be a problem. Not having enough history is what's going to get you into trouble. As far as the problem-focused history goes, it's a very brief, short history that typically is not going to be used very often in an optometric practice. It includes a chief complaint, 1 to 3 elements of the HPI, no review of systems, no past family or social history. So an example problem-focused history would be, my eye is red, that's the chief complaint. 1 element of the HPI is that it's my right eye that's red. End of history. That is a very brief history and not one that's going to get you a lot of information. An expanded problem-focused history is not a lot more information than the problem-focused. Once again, you're not going to perform a lot of expanded problem-focused histories. It would involve a chief complaint of my eye is red. It would have 1 to 3 elements of the HPI, so it's my right eye that's red. And then an ocular review of systems. Do you have any other ocular issues going on? And that's the end of the history. A detailed history, this is one you're going to use more often. It's a chief complaint, 4 elements of the HPI, an ocular review of systems plus 2 to 8 additional organ systems that you're going to review, and then 1 element from the past family or social history. And then the comprehensive history, this is the one you're going to do on every new patient, is a chief complaint, 4 elements of the HPI, an ocular review of systems and review of at least 9 additional systems, and then a complete past family and social history. This is the one you're going to do on your new patients. Now, this is a document I put together that I recommend using as a way to audit maybe previously performed examinations, and also to help you establish proper coding rules and guidelines for how you're going to submit today's claims. And so it's very easy to follow. You can see that it has all the elements of the HPI, the complete review of systems, and then your past family social history. And all you have to document is how many elements of each of those did you perform. And you would check box to the right here, either you did a brief HPI or you did an extended HPI, that you did a pertinent or an extended or a complete review of systems, and you did a pertinent or complete past family medical social history. Once you establish which of each of levels of those that you performed, then you can establish what level of history you performed, whether it be problem-focused, expanded problem-focused, detailed, or comprehensive. So whichever one of these columns furthest to the left has a checkbox in it, that is the level of your history. Now, these are the elements of an eye examination. These are the only elements that health insurance carriers really care about. Now, there's lots of other tests that you can do as part of an eye exam. There's lots of near testing you can do. You can do vergences. There's lots of FORIA testing you could do. But the reality is Medicare And other health carriers like Blue Cross Blue Shield, they don't really care about those tests. They care about the 13 tests that you have here, including the last one, which is orientation, mood, and effect. Now, a couple things that you want to make a note of here is pupils and irises, which is usually documented in 2 separate locations in your examination, count for 1 element of the exam. Therefore, to get credit for that 1 element of the exam, you have to make sure that you have documented both pupils and irises. As far as element number 13, orientation, mood, and effect, they're not asking you to do a psychological exam on your patients. You just need to establish that you made an observation on their orientation, their mood, and effect. And it can be as simple as is it normal or is it abnormal? Orientation, easy to measure. If the patient made their appointment a week ago for this morning and they show up on time for their appointment and they can tell you their name, their address, their date of birth, then they're oriented. I would put normal. As far as mood and effect goes, you have to make a judgment call. Does the patient seem to be normal? Do they seem to be depressed? Do they seem to be anxious? Once again, you can document it as normal or abnormal. That's all you have to do. Now, there's 4 types of ocular exams. There's the problem-focused, expanded problem-focused, detailed, and comprehensive. And as you go down this list, they become more detailed. All you have to do to establish the level of the exam is to be able to count how many elements of the exam did you perform. For a problem-focused exam, you can do 1 to 5 elements of the eye exam. And quite honestly, folks, you're not going to do very many problem-focused exams. 1 to 5 elements of the exam does not take very long when you turn on a slit lamp and you do acuities and you check the pressure. Typically, you do those things and you're already into the expanded problem-focused exam. That would be 6 to 8 elements of the exam. A detailed exam is 9 to 12 elements, and the comprehensive exam is all elements plus the mental status, the orientation, the mood, and the effect. So in order to establish the level of exam that you perform, it's really quite simple. You simply count the number of elements of the exam you perform. So this is an example here, once again, part of that document that I put together for auditing previously performed examinations to make sure that you correctly coded the exam, as well as helping you establish what's the correct level of exam you're performing today. So you can use this for both of those purposes. So you just establish how many elements of the exam did you perform. If it's 1 to 5, it's a problem-focused exam. If it's 6 to 8, it's expanded problem-focused. If it's 9 to 12, it's detailed. And 12 plus mental status is a comprehensive examination. That, coupled with the history, and then we're about to talk about medical decision-making, will help you establish what level of exam you're performing. As far as the decision-making goes, this is a little bit of a gray area, but I'm going to make it for you. I'm going to make it as simple for you as I can. There's 4 levels of decision-making. There's straightforward, moderate complexity, low complexity, and high complexity. But the reality of it is the vast majority of the exams you perform can be broken down into either low complexity, which are follow-up visits, which are examinations being performed on patients that have an established diagnosis from a previous examination that you performed, versus a moderate complexity, which is a new problem that walks in the door with the patient. Whether the patient is a new patient or established patient, if they have a new problem, one that you haven't diagnosed before, then moderate complexity is going to be the level of decision-making. So low complexity has a very limited number of diagnostic and treatment options, a very limited amount of complexity of data, and then a low risk of complications. This is how you decide your level of decision-making, is those 3 elements of the decision-making process. A moderate complexity is multiple diagnostic and treatment options, or a moderate amount and complexity of data, or a moderate risk of complications. So once again, these are basically decisions that you have to make. And I think the easiest way to establish the decision-making is really look at the diagnosis. If it's established, previously diagnosed problem, then low complexity is typically going to be correct for the decision-making. If it's a new problem, then moderate complexity is the way I would go. And this kind of shows it to you. I also have high complexity here. High complexity would be 3 new problems that the patient shows up with on the same visit. And I left off straightforward altogether. Straightforward is the lowest of low, and quite honestly, by definition, means the doctor never saw the patient. And I can't remember the last time I billed an office visit for a patient. In fact, I never have, where I actually did not see the patient and perform some test on the patient myself. So straightforward really isn't an option for an optometric practice. You've got decisions to be made here between low and moderate and high. And low and moderate is going to be the vast majority of decision-making that you're going to perform in an optometric practice. Now, when you take all 3 of those factors into play, the history, the exam, and the decision-making, and you put them on this cube that I'm showing you here, basically you just have to decide what was the level of the history, what was the level of the exam, and what was the level of decision-making. And for a new patient, you have to equal or exceed 3 out of 3 in a column going up and down. In this case, if you performed a comprehensive or a complete history, a complete exam, and a moderate complexity on the decision-making, the only one of these columns that has met 3 out of 3 in a column or exceeded it is the 99204. You can't call this for a new patient a 99205 because you would have had to have high complexity. And that's something that I do want to bring to your attention. If you're going to perform a 99205 or a 99215, a 5-level 99 exam, I think high complexity for the decision-making should always be part of that examination. For a new patient, there's no way to get around it. For an established patient, you could perform by looking at this cube, a 99215, because without a high complexity on decision-making, because you only need 2 out of 3 in a column going up and down to meet the level of that exam. And so you could do a 99215 with just a comprehensive history and comprehensive exam. However, I would caution you not to do that. If you're going to perform a 99215, I think you would need to do a comprehensive history, a comprehensive exam, and have a high level of decision-making. This example here, though, is for the 99214, where you have performed an expanded problem-focused history, but a detailed exam and moderate complexity on the decision-making. Because this is an established patient, you only have to equal or exceed 2 out of 3 in a column going up and down, which you've done that here in the 99214 column because you have a detailed exam and moderate decision-making. And so without getting 3 out of 3 in a column, you still can, for an established patient, meet the criteria here for a 99214. So it's easier to meet the criteria for a higher level exam for established patients than it is for new patients, because you only have to meet or exceed 2 out of 3 in a column going up and down. Now let's talk a little bit about procedures. There's lots of procedures that you can perform, broken down into 2 categories: bilateral procedures and unilateral procedures. And the difference between them is this: bilateral procedure has 1 fee for both eyes, typically does not require a modifier. An example is a 92083, a threshold visual field. Whether you perform that on 1 eye or both eyes, you're going to use the same procedure code, 92083, and you're going to get reimbursed the same amount, whether you do one eye or both eyes. So these are all bilateral procedure codes, from visual fields all the way down to the visually evoked potential. Unilateral procedures are billed separately per eye, which means that if you have a corneal foreign body in the right eye and a corneal foreign body in the left eye, you can bill for the right eye, and then you can bill separately for the left eye. You'll get paid 100% on the first eye, and you get paid 50% on the second eye, but you can bill each eye individually. Typically requires a modifier to identify whether it's the right eye or the left eye. Now let's talk about some forms that you're going to have to utilize in your practice, with the first one being a signature on file form. This is a form that's required for all patients, regardless of age. If you have a minor, a young patient, then you would have their parent sign the signature on file. This form allows you to share the diagnosis and procedure information with the patient's insurance so that you can get reimbursed. All patients with insurance must have a copy of a signature on file form in their file. This is an example here of a form that is a signature on file form. Once again, this is a form that I have in a PDF format, and if you need forms like this, feel free to email me. I have all of these in a PDF format, and I will have them sent to you via email so that you can have access to all these forms. There's no charge for them. I'll be happy to share them with you. Understanding whether or not a patient is new or established is extremely important, because as I showed you earlier, you have procedure codes for new patients and established patients, and they're different. For a Medicare patient, a new patient is defined as one that has not been examined in your office by you or any partner in the last 36 months. And an established patient is one that has been examined by either you or a partner in your office or potentially another office that you may own, and you've seen them in the last 36 months, then you are going to submit today's examination as an established patient. Now, the best way to understand whether or not this is going to apply to you is by looking at your tax ID number or possibly your NPI numbers. If the same tax ID number is going to show up on a patient's examination within 36 months of each other, then the second exam has to be established. So if you have multiple locations all under one tax ID number, then it's always going to be an established patient when you see them within 36 months of the initial examination. Timely filing requirements. For Medicare, you have 1 year. For many insurances, you have as little as 60 days, which means that from the date of service for a Medicare patient, you have exactly 1 year to submit the claim. And if you do not submit that claim within 1 year, the only thing you can do is bill the patient the 20% that Medicare is not reimbursed for. Keep in mind, though, all the other insurances that you may sign up for will have different filing requirement deadlines. As like I said, as little as 60 days. So it's really important to understand which ones have short, timely filing requirements and make sure those claims get submitted as soon as you possibly can so that you don't lose income because of timely filing. Now let's talk a little bit about codes. Since the ICD-10 codes came out a couple of years ago, the number of codes we have to deal with has increased tremendously. 10 times more codes now than what we had before. So routine exam codes such as the ZO1.00 and the ZO1.01, these are codes I typically use for infants, for toddlers, for pre-kindergarten age kids who are coming in and a lot of times have no refractive needs. Refractive ICD-10 codes for hyperopia and myopia follow certain trends here. The hyperopia, the H52.00 and the 010203. The difference on that last digit of these codes is with 1 being for the right eye, 2 being for the left eye, and 3 being bilateral. Same thing follows for the myopia. Now, we're going to talk a little bit about a dry eye patient. I'm going to go into a lot of detail here on determining what level of examination we're performing. And I'm going to go into a lot of detail on some of the laboratory tests and supplementary tests that you would perform on a dry eye patient. Remember, the elements of the exam that you have to look at is the history, the physical examination that you perform, how many elements of the exam you perform, and then the medical decision making. And then, of course, the diagnosis code in this case, which is a medical diagnosis code, will really drive this towards a medical examination. So for this patient, we do a comprehensive history. We do a detailed exam. We do at least 9 elements of the exam, which puts us in the detailed category. And then it's a new problem with this patient. Diagnosing dry eye for the first time makes this a 99214 level exam. So the chief complaint for this patient, they come in, they're complaining of dry eyes. 4 elements of the HPI is dry. Their eyes are dry all the time. Both eyes are dry. They've been using artificial tears, not really helping. Feels like there's grit in the eyes and occasional blurry vision. On a side note, folks, I will tell you, blurry vision is one of the #1 complaints for dry eye patients. Don't forget that. I think that's a complaint that many doctors overlook for their dry eye patients. Now, as far as performing the history here, in addition to a chief complaint, 4 elements of the HPI, then you need to have a review of the patient's history and review of systems. Now, you can have the patient fill out a health history questionnaire, and I would typically do that the first time I see the patient. But on an established examination like this, it seems a little redundant to have them fill out that yellow form, or in my case, it was a yellow health history form, but it seems redundant to fill out a health history form every time you see the patient. And in fact, patients don't want to do that. However,
hey, Dr. Botts here. We have
yes.
a question that trickled in. I'll go ahead and read it to you. Sorry to interrupt. But the question was, there's 2 here. Going back to being a provider, could one be a Medicaid provider for just medical and not vision? Is that possible?
For Medicaid, typically you can pick and choose which patients that you want to provide care for. In fact, you can choose, if you just want to see Medicaid patients 1 day out of the week, you can do that. I would say yes, you probably could choose just to be medical versus routine. I'm not sure when you'd want to do that, unless you're in a state where routine pays really poorly and medical pays much better. That might be a time to do that. However, I can see some of the difficulties you're going to run into is being able to establish before you schedule the patient whether it's going to be medical or routine. And so I think the technical answer is yes, you can. But the reality is you probably can't do it efficiently. I think you're going to more than likely going to have to do both medical and routine, because I don't think that you're going to be able to establish ahead of time every time whether it's going to be a medical exam or routine exam. Unfortunately, also, I'll tell you, with Medicaid, In some states, you can't perform medical care on Medicaid patients. In some states, they'll only let you do routine as an optometrist, which seems discriminatory, but it's a reality in several states.
Thank you. And another kind of follow-up question, I guess, is that say you end up doing a refraction on a patient that ends up needing cataract surgery. And so say you end up not finalizing the refraction because you're referring them out. Can you still bill the refraction even if you don't finalize a spectacle RX?
In that situation, yes, you can. And in fact, I would encourage you to bill that refraction to the patient, because I can't think of a more medically necessary refraction than one that you perform to establish it's time to send this patient out for cataract referral. So yes, in that case, and I do it often on all of my cataract referrals, I will do a refraction to establish I can't make them see any better, and then I will definitely charge or collect from the patient or bill it to insurance if I can.
Perfect. Thank you.
Great questions, and feel free to interrupt me with any more you have. So as far as the comprehensive history goes, instead of having the patient fill out that health history form again, you can actually just have the patient review, or you can ask them a few questions to see if their history's changed at all, and you can document just like I did here in the lower right corner. The date there is from the date that the patient actually filled out the health history form. You can check no changes. If nothing's changed, you can initial it, and that, along with the chief complaint and 4 elements of the HPI, you've just done a comprehensive history. It's important that you document everything you do. Every test that you perform has to be documented. And folks, if you don't document it, you didn't do it, you're not going to get credit for it. So here is where you're counting up the elements of the exam to determine what level of exam you've performed. You have your diagnosis and your treatment plan there at the bottom. And every test that you performed, you've documented. Let's talk a little bit about diagnosis codes. Now for dry eye, these are the 4 diagnosis codes for dry eye, including for the right eye, the left eye, and bilateral. I will encourage you folks to not utilize the unspecified codes whenever possible. I think insurance panels are going to deny unspecified codes. If there is a more specific code you can use, like right eye, left eye, bilateral, I would encourage you to use the most specific code you can. Other diagnosis code for dry eyes is keratoconjunctivitis sicca, not specified as Sjogren's, for either the right eye, left eye, bilateral. This is a code that I use often for my dry eye patients, especially if I'm going to prescribe Restasis, because Restasis typically will be denied by most insurance panels, in which you will send in an appeal, which will almost always be accepted. But one of the questions they may ask is, what is the diagnosis? And when Restasis was first brought to market many years ago, the diagnosis that it was utilized for was keratoconjunctivitis sicca, not specified as Sjogren's disease. Therefore, sometimes they expect you to use that diagnosis for your dry eye patients when you're going to prescribe Restasis. Other codes for my dry eye patients is blepharitis. Lots of different blepharitis codes here. Unfortunately, folks, when they came out with the ICD-10 codes, I think they made a huge omission by not giving us a code for meibomianitis, because oftentimes I have a diagnosis of meibomianitis on my dry eye patients. Unfortunately, there is no ICD-10 code to utilize, so you've got to come up with the best you can, which oftentimes is going to be dry eye, blepharitis, or the keratoconjunctivitis sicca. I'm going to talk a little bit here about different laboratory tests that you may perform on your dry eye. This is a test here, the Tear Lab, that I highly recommend if you're going to treat and more importantly, diagnose dry eye patients. I think a Tear Lab is especially important for that. It has a couple advantages. Number one, the instrument itself is typically free. Most often you can obtain a free Tear Lab if you are buying or purchasing a case of cartridges a month, which is typically about 20 patients per month. Then they will provide you the instrument for free. And therefore, it's a very small investment in treating dry eyes. It's required to use a QW modifier when you're using the CPT code for Tear Lab, which is 83861. The QW modifier is what's going to allow you to be reimbursed for performing a laboratory test in your office. The QW modifier means that you have acquired a CLIA waiver, which allows you to be reimbursed by insurance panels. The reason that you have to do a CLIA waiver is because most laboratory tests are typically performed in a certified laboratory. Your office is not a certified laboratory. However, that doesn't keep you from performing certain laboratory tests. And as long as you apply for and obtain the CLIA waiver, you can then perform a limited number of laboratory tests in your office for full reimbursement from insurance. Another procedure that you're going to perform on your dry eye patients is punctal occlusion. If you're performing it along with an office visit, like a 99214, you're going to have to use a 25 modifier with the office visit. As far as documenting the insertion of punctal plugs, the procedure code you're going to use is 68761, and you have to use a modifier, either an E1, E2, E3, E4 modifier for upper right, upper left, lower right, lower left lids, or you can use a right-left modifier for certain panels as well. Most insurances, including Medicare, are going to pay 100% of the first punctal plug that you insert on a given day, and they're going to pay you 50% of that reimbursement if you do a second plug, and you'll get no other reimbursement for a third or fourth plug on the same day. So the most you're going to get reimbursed for punctal plugs is 1.5 of the allowable, and that's regardless of whether you do 2 or 4 plugs on the same day. Now, typically, I only do 2 plugs. I usually do on the same day a lower right and a lower left. Now, here's an example of a super bill that shows you the procedure codes along with the diagnosis codes. And notice the lines here that draw from the diagnosis code to the procedure code. This is going to make it much easier for your billing person to be able to properly code and submit your claims when you are identifying what diagnosis code gives with the office visit, goes with the procedure codes, which modifiers to use for right, left, or E2, E4. And then the 25 modifier goes with the office visit. As far as filling out a HCFA form, this shows you the diagnosis code along with the procedure codes. And you can see you can do multiple tests on the same day. This is a typical dry eye evaluation in my office, where you'll do an office visit, you'll do a Tear Lab. With the Tear Lab, the 83861, the QW modifier is the CLIA waiver. The right and left modifier is because you're going to do this test on the right eye and the left eye, and you're going to bill for the right eye and the left eye, and you're going to get reimbursed for the right eye and the left eye. The closure of the punctal, or the punctal occlusion, the 68761 with the E2 and the E4 modifier. And then if you take a photo, or in this case, you could do a keratograph with a non-invasive tear breakup. The 92285 is the procedure code I'd use for that. And you can get reimbursed for all these procedures on the same day. The non-invasive tear breakup time, I think, is critical for diagnosing and treating dry eye patients. What's so important about these tests for dry eye that we now have is that they give you an ability to tell the patient whether or not their treatment plan is working. It tells you how bad the dry eye is. It gives you information that you can share with the patient on whether or not their treatment is making the condition better, or is it getting worse. And this is important because it motivates patients to be compliant. There's no better way to get a patient to perform the treatment that you want them to do, whether it's artificial tears or omega-3 supplements, or taking prescription drops like Restasis or Xiidra. There's no better way to get them to be compliant than to show them that it's working. And that's what these tests, I think, are so important in helping us do for our dry eye patients. Meibography, I think, is just so important for establishing what shape are the meibomian glands in for dry eye patients, whether they are fully functioning or barely functioning or not functioning at all. Inflammadry is another test that I think is critical in diagnosing and monitoring dry eye patients. This test detects elevated levels of MMP9. It's a very easy test to perform. As you can see here, it basically is a test that you touch to the conjunctiva, you draw up a little bit of tear, you let it sit for 10 minutes, and then it's going to give you a reading of positive or a light positive, a dark positive, or maybe a trace or a negative. Now, the way I use this test is, if it's positive, then I typically will consider prescribing Restasis. If it's positive, I typically will not put in a punctal plug until the inflammation is subsides or is gone. I would typically treat them with a steroid or Restasis or something to get rid of the inflammation before I'd put a punctal plug on. To submit this test, you use 83516 with a QW modifier because it is a CLIA waived test, and then 2 units. You can do this on one line for both eyes with 2 units. The CLIA waiver is a simple application that you fill out. Typically, TearLab will help you process the application, and along with your $150, you will get a CLIA waiver good for about 3 years.
A couple of quick questions here, Dr. Botts.
Sure.
First one, well, we'll ask this one first since it's kind of right on what you're speaking about here, but a watcher just asked here, a viewer, why did you use a 9200 code for the dry eye evaluation instead of a 9900 code?
So the way I determine 99 codes versus 92 codes typically is based on reimbursement. Depending on the state you practice in, your allowables between the 99 codes and the 92 codes will vary. For the most part, for most states, and now I'm going to talk about Medicare here, if you're looking at a new patient, a 99204 will reimburse better than a 92004. And so if that's the case, I typically would do the 99204 because I'm going to get paid more. Now, it's your choice though. If you want to get paid less, you can intentionally do the 92004 and get paid a lower reimbursement. As far as the 92002 or the 92012, I typically utilize the 92012 most often for office visits on follow-up patients because it pays better. The 92012 is going to pay better than the 99213 or the 99212, which the 92012 I think is comparable to the 99213. And so I oftentimes will use the 92012 in those cases. As far as the examples I'm giving you here today, most of the examples I'm giving you are using the 99 codes, because the 99 codes, I think, need a little more explanation as far as meeting the levels of the 99 codes, and that's why I'm using them as the example here. But you can do either. There is no right or wrong answer. If you meet the criteria for a 92 code or a 99 code, you can use either. Realize that only optometrists and ophthalmologists, only eye doctors get to use the 92 codes. They are explicit for ophthalmology or optometry. The 99 codes are used by everybody else, plus we can use them as well. So there's no right or wrong answer to which one you use.
Great. And another question kind of touches back on a previous question about refraction and cataract surgery. The question is that if a patient has an IMED or a VSP and you do a refraction, does the prescription need to be finalized to bill the refraction? Or I'm sorry, so going back, let me rephrase the question here. If you see that a patient and you're referring that patient for cataract surgery, but you bill the refraction to their vision plan on that day, how do you handle that when the patient comes back post-surgery for a visit for refraction, just say? Can you bill that twice, or is that patient paying out of pocket for one of them? How does that work?
Okay, so it's a great question, and it's all about coordination of benefits. And the way most routine vision plans go is that some will coordinate the refraction, such as IMED and VSP, in that you can submit the refraction to the routine vision plan. You can submit the medical exam to the medical insurance and get paid for both. You'll get paid for the medical examination, for the medical insurance. You get paid for refraction from the routine vision plan. That's a coordination of benefits. And in that case, typically you have to submit the refraction to the medical plan first, get it denied, and then submit it to the routine insurance. Now, to answer the question is, can you get, how do you handle doing two refractions, say, in the same year? Routine insurance is only going to pay for one of them. The patient's going to end up paying for the other. Which one you submit to routine and which one the patient pays for can be up to you. But they're only going to pay for one. Patient's going to be responsible for the other. And quite honestly, there's no problem with that, because the patient has a medical issue. And if they have a medical issue that requires two refractions, then you're going to perform two refractions. And the patient's going to be responsible for the other one. You're going to explain it to them. You can explain to them that this is just following their insurance rules, and the patient will typically pay it and not question it. So those are the guidelines that we have to follow, and you explain it to the patient, and then you charge accordingly.
Okay, perfect.
Great question. So now let's talk a little bit about punctal plugs. I do a lot of punctal plugs, and like I said, I use that inflammadry to kind of lead the way here on whether or not I'm going to put a punctal plug in place. Punctal plugs have a global period that's 10 days, which means that if you are going to utilize, for example, if you're going to utilize collagen plugs, like the short-acting collagen plugs that melt after, say, a week's time, if you're going to use those plugs first, then have the patient come back, and if they got an improvement, then put a silicone plug in place. You have to put those silicone plugs in place at least 10 days after you did the original procedure. Because there's a 10-day global period on this, anytime you see that patient during that 10-day global period of the punctal plug and you put in another punctal plug, you're not going to get paid for the second punctal plug during the 10-day global period. So if you're going to see the patient back and put in another plug, you need to wait at least 10 days to put that second set of plugs in, or they're free. You'll submit the claim for the second set of plugs, same as you do the first one. However, you may not be submitting it with an office visit because an office visit may not be necessary, or you may be performing an office visit if necessary and billing it at the same time. So once again, you need to document everything that you've done, including your plan of inserting plugs, ordering inflammatory. It's very, very important when you are doing tests or doing laboratory tests that you document that you're ordering those tests to be done. And in this patient, we also, in addition to doing the office visit and the punctal plug occlusion and the inflammatory, this particular example of a patient is not getting any better. In fact, they're getting worse. And the dry eye is escalating. And so I put a amniotic membrane on this patient. So looking at the codes here, you have the office visit with a 25 modifier because you're doing additional procedures on the same day. The 68761 is the punctal plug occlusion with an E2 and an E4 modifier. Since you're doing 2 eyes, you're going to bill it twice and you're going to get paid because these are unilateral procedures. The 83516, that is the inflammatory with a QW modifier. If you move to the right, past the diagnosis pointer and move past the charge, you'll see in box G, days or units, you're going to see 2 there. You're going to use a 2 because you're going to do both eyes, but you can build this on one line as long as you use 2 units for the inflammatory. And then the last code there, the 65778, that is for the amniotic membrane. That's the placement of the amniotic membrane on the cornea. You'll notice the reimbursement on that is quite high. The Medicare allowable in my area is over $1,300 for an amniotic membrane. And that is correct. The Medicare is going to reimburse you that amount for inserting an amniotic membrane. And that's 1 eye, 1 amniotic membrane. If you were doing both, you'd get paid for doing both. But typically, you would not put an amniotic membrane on 2 eyes on the same day. So let's talk a little bit about amniotic membranes, because this is really a newer procedure that is becoming more and more common. I'm doing more and more of these on patients, not just for dry eye, but really any condition that requires a healing to occur. And there's 2 different types of amniotic membranes. There's dry and there's frozen. And the frozen is the Procara, requires you to keep the membrane frozen in a freezer in your office. When you're ready to use it, you're going to thaw it out and you're going to put it on the patient's eye. It comes with a ring to keep it in place. The downside to it is it's a little uncomfortable for the patient because it does have a ring that keeps it in place. So the patient definitely feels it under their lid. The dry membrane, a little easier to maintain in your office because it's dry. You don't have to keep it frozen. It stays in a box until you're ready to use it. You insert it, and then you put a bandage contact lens over the top of it to keep it in place. These are typically going to take 2 to 5 days to melt and absorb into the cornea. Once the membrane is gone, you'll remove the bandage contact lens, or you'll move the ring in the case of a Procara. Once again, these are used for increasing the healing process, and there's no global period associated with these. So if you see the patient the next day, you can bill an office visit. Typically, though, when you're doing a amniotic membrane, the office visit is typically part of the procedure of putting an amniotic membrane in place. As far as punctal plugs go, there's lots of different ones out there. There are the short-acting collagen plugs. There's the 90-day collagen plug, and now there's a 180-day collagen plug. These are plugs that will melt over time. They're very, very useful. I use typically the 90-day plug. I see the patient usually 90 days later, and if we need to put another set of plugs in, we do, and insurance will pay you every time you put a set of plugs in, whether it's every 90 days or every 6 months or once a year. However often you need to put the plugs in, your insurance is going to reimburse you for it. It's up to your medical decision making to decide when and how often to put a plug in. Now, I throw this slide in because I personally was very, very surprised at how many dry eye patients I started seeing after I used the tear lab, the Inflamadry, and the keratograph in my practice, and really started paying attention to these patients. And what I found is with having the tear lab and the Inflamadry, the keratograph, it was very easy to monitor these patients and show success. But it also required me to see these patients more often. And so the vast majority of the income you generate from dry eye patients is on the office visits. The tests you do, the tear labs, the keratograph, the Inflamadry, they are going to generate a small amount of income from your practice, as does the punctal plugs and, of course, the amniotic membranes. But the vast majority of what you're going to do is you're going to do a lot more office visits, and these are short visits. These visits I schedule typically as same amount of time as I'd schedule for a contact lens check. And so they don't take much of your time. But I've never seen probably a change in my practice as far as being very patient focused and giving a great experience to my patient than when I start treating their dry eye, because the vast majority of these 300 plus dry eye patients that I see now, these were patients that were coming in my office every year. And I was just not diagnosing the dry eye because I didn't have the technology available to do so. Once I added the technology, and I added it up after 12 months and realized a very large profit, not just gross exam fee, but a profit of just a little under $100,000. It's probably one of the biggest increases in income I've seen in my practice in my career. And that doesn't even include the satisfaction that I've gotten from providing better care for my patients, and the satisfaction my patients have gotten from having better care provided to them. So I would encourage all of you to start that transition to medical coding and medical billing as soon as you open your practices. Don't make the mistake I did and waiting 10, 15 years before actually doing the medical billing model of optometry in my practice. You need to evaluate your fee schedule. And of course, you need to credential for the vision and the medical insurances that you want to be part of. Treat everything your license allows. You folks have such better education than I received way back when. You're coming out with such better skills. You're already better clinicians. So treat everything that your license allows. Charge for every procedure you perform. Realize you're going to have to invest in new technology. You're going to have to spend money to grow your practice. And then find your comfort level with any of the tests that we talked about today. You find your comfort level, establish your ability to put in punctal plugs, to insert an amniotic membrane. and add that to your ability to provide excellent patient care. And when you do that, you are going to be able to provide so much better care for your patients. Now, once again, here's my email address. That's really all I have. I'm more than happy to answer any questions you have now, and you're more than welcome to send me questions via my email. That's really the best way to contact me. And when you do, please let me know that you were on this presentation, so I know where you got the information from, and I'll be happy to answer any questions you have.
Yeah, you know, just a big thank you for taking the time to hang out with us tonight and share all the information here with our viewers. Once again, everybody, if you have any questions, don't hesitate to you know, contact us. We'll put you in touch with Dr. Botts, or you can email him directly. His email address is right there on the slide there at it's drvision@claimdoctor.net. You can always check out www.claimdoctor.net for more information as well. And you know, very complex topic. We you know, just scratched the surface, I guess, really, but a lot of good information there. And you know, I think this definitely will give our readers and our watchers, you know, all the nuts and bolts to really get started and make a difference in practice. So thanks again for taking the time tonight. And I don't see any other questions for now, but I'm sure there's going to be many trickling in. So I'm sure we'll be in touch very soon. So with that being said, have a great night, everybody, and thanks for watching.